is a form that it discusses CPR and the treatment that a patient wants going forward, or treatment that they don't want going forward. And then we would discuss their condition, any symptoms that they're having, whether they're at the hospice for end-of-life care or for symptom management, because we have a lot of people who come for symptom management. They might be in pain or have nausea and vomiting, or different symptoms, so they come to us, we can help rectify that, and then they'll go back home after that. So it's not just end-of-life care at the hospice.
I just want to explore that a little bit further, because the general perception out there in the community is that when you mention hospice, people say, oh, that's where people go to die. But you've mentioned something else, symptom management.
Yeah.
So help me understand, and help our audience understand, why do people go to a hospice? What are the different reasons?
So symptom management, that could be if we in the community they can't get on top of the pain, nausea and vomiting, could be constipation, it could just be that medication needs titrating. Sometimes people come to the hospice just to have a look round. If they have got a terminal illness, it might be that they come to have a look round to see what it's like before then being admitted in the future. Some people want to come to the hospice for end-of-life care, but like, I think the word hospice has very scary connotations to it, and people think, oh, it's a very scary place, but it's not. It's oddly, it's a really nice place. Like, it's a lovely place to be, and I think a lot of people after visiting get a lot of comfort in knowing that there's the people there to help, and that it is quite a nice environment. It's not all doom and gloom.
No.
So
you mentioned a couple of things there, a couple of terminology. One is one was terminal. There may be someone who's listening who doesn't understand what terminal actually means. What does terminal actually mean?
Terminal means that the disease will end their life.
Okay.
But it doesn't necessarily mean, if someone's terminal, doesn't mean that they're going to die tomorrow, or so someone can live with a terminal illness for quite some time, maybe perhaps years. So for example, someone could be diagnosed with a cancer, and they could be told that it's terminal, but they still might live for another year or 2 years. It just means that cancer is going to kill them in the end. So
help me understand that, so the cancer is not curable.
Yeah.
Or treatable, or there's a difference, isn't there, between curable and treatable?
Yeah.
What are those differences?
Because someone might have treatment, it's not to cure them, it's not going to cure them, but it might make them live a little bit longer.
Okay.
Or they might have treatment that will kind of relieve symptoms, but again, it's not a cure, and it's just going to make the last.
So there is this misunderstanding amongst many people out there in the community that they hear the word terminal and they think, oh, end of life.
Yeah.
And many people may think that, oh, it's going to happen days, weeks, months. I've spoken to a lot of people and they never think years, but the reality is that a lot of people do actually live for years, don't they, with that terminal diagnosis. Now, one of the ways that people can live better lives, and I suppose, is that what we call palliative care?
Yeah.
Okay. So terminal illness, diagnosis, palliative care is about helping them to manage their symptoms, pain, any other issues that happen. And are they only managed as an inpatient unit? Can they only be managed as
No, so we have a community team. So it might be that someone's under palliative care, but they might not be under the hospice. They might have carers, or be managed by the GP, or they might be managed by Western Park Hospital or their specialist team. But they can be referred to the hospice if they are struggling with anything. They can self-refer as well as getting the doctors to refer. But we do have a community team that will go out and see the patient and try and manage the symptoms at home, especially if the patient doesn't want to come into the hospice. Then we can manage the symptoms at home and try and take care of them at home.
So people have a choice.
Yeah.
It's not that it's the inpatient unit or nothing.
No.
Is that what we mean when we talk about personalised care?
Yeah, and I think that's what a lot of people do. Like I said, they'll come into the hospice to have a look, or they'll just come in for a short admission just to kind of get a feel for it. And those people will say that they didn't want to come to the hospice. It's quite scary, and they always afterwards they'll say I'd come back, and that it's nowhere near as scary as what they think it is. And it's just about what's important to us is being able to provide the care that patient wants. So if they want to come into the hospice, they can do that. If they want to stay at home, then we need to be able to provide as much care as we can to fulfil their wishes to stay at home.
Right, okay. So is that just something that Rotherham Hospice does, or are other hospices do similar things or the same?
As far as I'm aware, not everyone has a community team.
Okay.
Some hospices do, but not everyone. So it is, and I think our community team just won an award.
Yes, they did.
A couple of weekends ago.
Amazing.
Yeah.
Yeah, it was an
So
amazing
they
thing,
do a
wasn't it,
really
Rotherham
good job.
Hospice? Yeah.
I think they cover quite a large area compared to most.
I've had some colleagues from Rotherham Hospice's community team on previous programme, and they said that there's about 500 patients that they've got.
Yeah.
I think 300 are active patients in the sense that they have ongoing support from the hospice team, the community, what we call the hospice at home team.
Yep.
And then there's another 200 who can potentially act as and when they need us, which is amazing. And the reason I'm asking that question is because this programme goes out across the UK, and people may be listening from anywhere in the UK. There are lots of hospices across the whole of the UK, so no matter where you live, there will be a hospice close to you. If you are going through anything in terms of cancer, life-limiting illnesses, anything like that, palliative, terminal, any of those terminology that you've come across, please reach out to your local hospice. And you would be amazed at the amount of support and the help that's available. If you can't find a number, just turn up at the, get an address and just turn up at reception, and just ask to see, speak to someone, and you will find that there is so much support that you can get at a hospice. And the other thing now that we found is, 30 years ago, most people wouldn't even say the word cancer, would they?
No.
I think you're far too young to remember that. But 30 years ago, people said the C word.
Yeah,
they?
yeah.
And that's a key thing. And now they mention cancer all the time, don't they? And the other thing I found is that, and this is really important, because treatments, cures, early detection, those kinds of things, there's so much of that now, and there are so many cancers. I think there's 200 plus cancers, isn't there?
Yeah.
But the treatments and all of that support out there is, it's just super amazing. Yeah. So, what kinds of things do you actually teach as a clinical skills trainer?
So as a clinical skills trainer, what we'd say, obviously clinical skills I'd be training, so that'd be things like anything clinical based, so it could be blood transfusions, observations, with so PICC line training, which is like an IV cannula that goes in to like a main your main artery vein, and it's because at the hospice we don't have constant people that come in with these needs. So like yesterday we did tracheostomy training. We had a specialist nurse come in and do the training. A tracheostomy is like surgery that someone has. If they might have some cancer or tumours in the trachea or the esophagus, which is your windpipe. Yeah. So it'd just be like a hole in a tube that bypasses that, so that someone was able to breathe without like the tumour blocking their airway, which is, you know, obviously we need training on that, and it's someone's airway, so it can be quite scary. So we've had specialist nurses coming in to do that training. They came in yesterday, they're going to come in tomorrow. And then because we don't see those things often, we'll do the training like every 6 months.
Okay.
So it's the same for everything that we do.
So is this about reskilling people? Because I was assuming that if you're a nurse and on the hospice unit, and they're also the clinical nurse specialists, aren't they? Majority of them. There may be some sort of healthcare who are learning.
Yeah.
But I would have thought that a clinical nurse specialist would know all this.
Yeah.
So what's the need for this training then?
So they do know it all. It's about more giving the staff confidence to look after the patients, and to be able to give the best care that they can and make sure that they're up to spec, because things change. Not a lot, like usually things stay mostly the same, but like things do change different for different things. But it's more about like just giving the staff confidence to care for the patients properly, and just keep them up to date.
And I suppose one of the things that you said earlier was that it's about they may not use that particular skill for months.
Yeah.
And then I suppose if you're not using it all the time, you may forget. It's just natural, isn't it?
Yeah, and we want to do what's safe for the patient, because we're all here for our patients, and that's what matters most to us. So it's just about making sure that everything's getting done properly. If anyone needs any extra training, we can offer that. We always say if you don't feel confident doing something, then just don't do it. And me and my manager, the educator, we can work with that staff member to make sure that they are confident in what they're doing, and to make sure the patient gets proper care.
So it's a very important part of the hospice, isn't it?
Yeah.
A trainer, a clinical skills trainer.
Yeah. Because if you want, again, I was going to keep repeating myself, but you want to make sure that your patients are safe, and that you're doing the absolute most that you can for that person. So like I said, we're happy to, even if someone's only done training last month, if they're not confident on it, we can do it again with them. Or if a patient comes in with something like a tracheostomy, and staff haven't had that training for a few months, or they've not seen that particular thing that a patient has, we can update them, we can give them support, we can, just make sure that they know what they're doing.
So you've said earlier that a specialist nurse that came in. Is that a normal sort of practice that you bring specialists in, or is there some training that you deliver yourself?
Yeah, so with some things like the tracheostomy, because that is like a specialised area of care, and we had some nurses who were coming in doing some extra care for one of our patients who had a tracheostomy, and they said that they could do some training.
Okay.
But we do, so I do like blood transfusion training, anything that I'm trained in I can do the training for. Recently I've done a CPR.
Okay.
I've done the training for CPR so that I can then train other people.
Like a train the trainer.
Like a train the trainer,
Right,
for
okay.
CPR.
Yeah, right.
So me and Lindsay are going to start, because at the minute we pay someone to come and do CPR
Right,
training. I think it's about £200 a month.
Okay, so that's really a key point, I think, because as a hospice, hospices get a small amount of money from the NHS, but the rest of it is funding, isn't it? Donations, funding, and the generosity of the public out there. And it's not a few £100 or a few £1,000. We're talking tens of millions, aren't we?
Yeah.
That we hospices have to raise. And I suppose what you've just said to me about bringing specialist trainers in, you have to pay them.
Yeah.
But if you as an employee have that training, have that skill, and then it's saving the hospice money. So what we can then do is spend that money on patient care.
Yeah.
So if you've just joined us, you are listening to Care Across Cultures with me, Mirban Hussain, your host. I've been talking to Rosie Connolly, who is a clinical skills trainer at Rotherham Hospice. We've been sharing what a clinical skills trainer does. We're going into a short break soon, and we will carry on the conversation when we come back. See you shortly. Assalamu alaikum, welcome back to Care Across Culture with me, your host Mirban Hussain. Thank you for joining us. If you've just joined us, we're talking about clinical skills trainer at Rotherham Hospice, and I've been chatting to Rosie Connolly, one of my colleagues. You're listening to us on Link FM 96.7. I'd love you to join the conversation on 0114 261 8181, or you can send us a text message on 079 398 49339. So, Rosie, thinking about a hospice and you as a skills trainer, the question I want to ask now is that how do you teach both practical skills and the caring side of hospice work? And or do you do that?
Yeah, so the practical skills is more of like teaching somebody how to do something. We have like a simulation dummy where we can practice the skills on him. And then we so I would teach to the staff, and then they would show me back, show me what they've learned, and they'd practice the skills on our Bob, we call him. Bob, yeah. And then they would, so like you said earlier, a lot of the staff already have these skills, so it's just an update. So if it's just an update, we'll go through it and they can practice, and then I'm
just going to interrupt you there. So I think just want to clarify this. It's not that you're teaching staff new skills. They already they're fully trained. It's more of an update, isn't it?
Well, it depends.
Does it?
Yeah.
Right, okay.
We have got some like newly qualified staff or new staff, so I would be teaching them the skill. And then we'd work with them on the ward as well with the patients, and give them support so that they're not just learning the skill and then straight going to the patient. If someone already has that skill, then it'll just be an update, and then they are then free to go onto the ward and practice their skills on the patients, as long as they feel confident enough to do that. If they don't and they don't feel unsure, then we can keep offering them support.
Right, so we've got practical skills.
Practical skills, yeah.
What about the caring aspect? Because is there some training that you do on that?
I think you have to naturally be a caring person,
Mm-hmm.
and it should come naturally to you to be to care for your patients and their loved ones. We do offer some training that's a bit more, not really practical skills, but like recognising dying, advanced communication skills, leadership, that kind of thing. Which is, some of it's outsourced and some of it we can do ourselves, but that is harder to kind of teach because, yeah, like I said, you need to have the empathy, you need to have that caring side to start
off with.
Yeah.
Which leads me to thinking that, so we're going to talk a little bit about culture, traditions, beliefs, value systems now. Rotherham is a diverse town. Does culture affect the way that you train staff to care for patients? And before you answer that, when I talk about culture, what I'm talking about is not necessarily a culture which is visibly different, you know, like an ethnic minority or a religion. I'm talking about the whole sort of, you know, all those different cultures out there in terms of socioeconomic deprivation, in terms of drug and alcohol, learning disability, all of those kinds of things. Because I'm sure that if you're sort of the people who have cancer or life-limiting illness don't just come from one specific group of patients, do they?
No.
No.
It's a bit of a tricky question, because to me, everyone is, like you've said earlier, is treated with person-centred care.
Yeah.
So obviously culture is a big part of everyone,
Of course.
and their culture obviously to that person. So you would naturally get to know your patient, and that includes their cultures and, you know, everything about them, and you'd care for them with
Right.
how they want to.
Okay.
Obviously culture comes into it in the, if they've got specific needs or requests or whatever, then we'd accommodate that.
Let me sort of ask another question which might sort of hopefully make this a bit simpler. Many different cultures have views about touch and personal care. Can you give me an example of how you would handle this in training?
So in training, it's going to be similar to my answer.
Right, is it? Okay.
Because
Yeah.
no matter who you are, what culture
Yeah.
you've got, you need to ask everyone for consent before touching him anyway. So
Yeah.
like, it doesn't really relate to, it might relate to culture or religion or you know, but everyone should have that choice of whether they're happy with male or female caregivers, whether they want to be touched, what kind of clothing they might wear, or you know, any kind of specific requirements. So it's just, like I said, getting to know your patient. So I would train people that you ask for consent,
Yes.
and that you're constantly talking to people, the patient, and telling them what you're doing, why you're doing it, and asking, is it okay, or can you just, you know, do this for me? Do you know what I mean? So
the gold standard,
Yeah.
personalised care,
yeah,
that covers it.
yeah,
At the hospice, we provide personalised care,
yeah,
and that encompasses everything else that...
yeah, and obviously culture and different demographics need to be recognised,
Yeah.
and that will always be talked about, you know, with the patient and what they want going forward. And you know, we do ask questions about culture and preferences for people, but as like the bog standard is to it's personalised care.
It's personalised care.
Yeah.
No, that's fine. That's fine. Thank you. It's a difficult one, that one. As a trainer, I was just trying to understand whether there was any training course session that you deliver, which was around
Specific needs.
specifically about those kinds of needs. But you've answered it really well in terms of it's something about compassion, empathy that someone has, because I think nursing it's a calling, isn't it?
Yeah, and I guess for me, again, going back to you should be a kind and caring person, like that should be for everyone.
Yes.
So I don't understand how you could work in care and not
Yes.
and not include everyone. You know, like you shouldn't have them biases to start with. Like every human being is a human being, and you know you should be caring for that with equity. So like not like equally, but
not
like I said, you acknowledging, yeah. I
think that you touched on a particular passion of mine, unconscious bias, which is not for this programme, but unconscious bias exists.
Yeah.
In all of us, and I think the key to unlocking that is to be aware.
Yeah.
And you know. To actively do something about it.
Yeah. We do have we have EDI training.
Yeah.
Obviously, we've got you doing some training.
Yes,
tomorrow,
I'm delivering some tomorrow morning as well, aren't I? Yeah.
And we're going to try and get more face-to-face training, aren't we, so that you can spend more time with staff and they can get to know you and feel safe.
I think that's
questions.
It's a really important thing, that, isn't it? Because there's training which is online, or there's training which is face to face. Now I'm going to ask you a personal question. Which do you prefer?
Face to face.
Face to face, and why?
Yeah, it's just more engaging. The online training can be a bit of a, you're just kind of clicking through it. I find it difficult to do the online training.
Yeah.
And it's nice, I think, if you're doing it face to face, usually there's a group here.
Right.
It comes
and
under
that
as part of your work hours.
Yeah. And then I suppose you do build up relationships as well. Because as a trainer, you may not all be from the same team.
Yeah.
You might work at the same organisation, but daily you may never meet because you do something different, or you're on a different shift, and it builds those relationships. And thank you for that. Okay. What's the hardest thing to teach, and why? What have you come across personally?
The hardest thing in hospice care is when you come from acute medicine or acute surgery. So acute is kind of when someone's sick there and then, basically. So if you work in a hospital, they're usually acute settings. So in those settings, it's your job to kind of escalate any concerns that you've got, and you're fighting to keep people alive. Whereas in the hospice, it's more patient centred in the depending on what they want, what treatment they want going forward, whether they want to be escalated. Because sometimes people might need to go from the hospice to the hospital. For certain treatments, we do try and do most treatments we can do at the hospice now, but it's I can't remember the question. What?
Okay. It's the question was, what's the most difficult to teach and why?
Oh yeah, so so when you're going from that mindset of everything is kind of like everything's not rushed, but you're kind of acting quickly on things,
right?
And you're escalating and you're trying to save someone's life. Whereas in the hospice, someone might not want escalating to the hospital, and that's their choice. So it might just be that you offer treatment that would manage their symptoms, but you're not going to cure them. So it's more about keeping that patient comfortable and keeping them as happy as you can, you know, in those stages of their life. Whereas in the hospital, it's hard to explain, but in the hospital, because you're actioning a lot of things.
You're treating someone on because of the acute thing that you said.
Yeah.
In a hospital, you know, you're there because, you know, there's something that's immediately wrong.
Yeah.
And we need to fix that there and then as quickly as we can. As to stabilise, I suppose.
Yeah.
Does that sort of make sense?
Yeah. And in the hospice, it can be difficult to take that step back and kind of let go of treating the patient for what you think's best and not for what how it's going to make them feel, because that's what's more important in the hospice, is what your patient wants and how they feel going forward, and whether it's just for management of symptoms or
okay. So another question is, what do new staff struggle with most, and how do you know when they're ready? So you've delivered, you know, you've identified some training.
Yeah.
You delivered the training. So, you know, they've had an hour, 2 hours a day. Is there any follow-up that you carry out as trainers?
Yeah,
okay.
Definitely. So we're always in contact with the staff, and we always encourage them if you just want some support. So the inpatient unit is upstairs from my office, so I'll spend time on the inpatient unit or into community, and I'll say to people, if someone might be coming in, a patient coming in for a blood transfusion, and I can go and do the blood transfusion with staff, offer that support, or they can come and spend time with me and Bob and just do some extra practice on the clinical skills.
So all of what you've been telling me and what I've been hearing is that it's not that you're a trainer in a classroom.
No.
People come to you, you give them the training and then they go away. It's much more involved.
Yeah, it's constant support.
It's constant support
Yeah.
as well, which is really, really important, isn't it?
Yeah.
And I suppose from that, you know, that'd be really good for you, wouldn't it, in terms of, okay, I've delivered this training. I can go and observe people actually carrying it out.
Yeah.
And then I think, you know, one of the things that I'm just thinking to myself now is that, okay, so delivered training, observed, and then feedback if I need to change. If it's working, okay, that's what I do, that's what I need to do. If it's not working, okay, do I need to go back and then... Do you find yourself having to amend training when you've done some observations?
Yeah, so I did some training for the first time yesterday on falls. It's not new training, it's just new. It were a new session that I'd got together, and I'm doing that again tomorrow. But I'm going to make some changes for it later on today, just because it's the first time I've run that session.
Right.
So sometimes you don't know until you've run the session how smoothly it's going to run. I've got a mixed group of people from nurses and healthcare, so they're at mixed ability, so I think I want to just make it a bit more kind of split and a bit more specific towards the nurses and to the healthcares and what they can both do.
And that's a really important point that you mentioned, because as a trainer you know your subject, you know what you've got to deliver. But then if the audience comes and they're all from different abilities, different areas, different team, and you've just got one training that you can't sort of amend it there and then, can you?
Yeah.
So how do you manage that? Say that, you know, not only did you have nurses and healthcare, but you maybe had some volunteers, or you had some doctors there, or you had somebody else. How do you manage that?
It can be difficult, especially like you've seen me today. I can use words that to me make sense, but to other people might not make sense.
Yes.
And that can be hard when you're used to kind of using that language. But for a mixed group, what I tend to do is start from the bottom.
Okay.
Make sure everything's explained properly, and then just kind of work its way up so that everyone gets something from the session.
Have you had a really personal question now? Have you had a training session where someone didn't really understand at all what they were doing or what you were telling them, and they kept asking you questions, and did it sort of disrupt the whole sort of learning process? Or
For me, I always encourage in my training sessions, they tend to be small groups, and I always encourage for people to just kind of ask questions, and I'd rather have a two-way conversation about things than just be stood there kind of going through a presentation. So I welcome that. I ask people to...
Which is good.
Yeah.
Okay, that's great, thank you. So if you've just joined us, you are listening to Care Across Cultures with me, Mehrban Hussain, your host. I've been talking to the amazing and wonderful Rosie Connolly, one of my colleagues at Rotherham Hospice, who's a clinical skills trainer. Rosie has been sharing that she was a registered nurse in gastroenterology, which apparently is from your throat down to your bum, the words that she actually used. I'm not quite sure whether we can use that word on radio, but it has been used. And then she changed to becoming a clinical skills trainer. Yeah. And from what Rosie has been sharing, I think it's turned out to be a really fulfilling change for you, hasn't it?
Yeah.
And I suppose also the timing, you know, in terms of it's more like a 9-5 job, isn't it? This one,
Yeah.
rather with the training, this with nurses, there's shifts and there's all that, and the Saturday working and weekends and all that kind of, you know, bank holidays and that kind of stuff, because that's how the shift patterns work for nurses, don't they? Nurses and medics. That's how they work. Okay, we are coming to close to the end of the programme. If you've got any questions, our phone lines are open. Please give us a call, or you can send us a text message on WhatsApp. If you do want to get to know more about a hospice, reach out to your local one. I talk about Rotherham Hospice because that's where I'm employed, and you know, we talk about St Luke's and Wakefield and Barnsley and Bluebell Wood and all these hospices, but these are the closest ones to me. But wherever you are, wherever you live in the UK, you will have an hospice close to you. If you are struggling with cancer, life-limiting illnesses, and you want to know more, please reach out to a hospice and just engage. So, thank you. I've got some other questions, but you've already answered most. I was talking about, is it just classrooms or the wards, but you were on the wards as well, aren't you? And I was going to ask you whether you still care for patients, but sometimes you do. Okay. Tell me something unexpected that's happened recently, work-wise. If nothing's happened, it doesn't matter. Yeah.
I had an answer for this question. I can't
Did you?
remember it.
Okay, we'll come back to it. You know, we're just having a conversation, you and I. Okay, it's pretty heavy work, intensive work.
Mm-hmm.
You might just be a trainer, but you're a registered nurse. You're still a registered nurse. You're a qualified nurse, and we are talking about working with people who have a terminal illness, who potentially may be at end of life, and families. It's very emotional, this, isn't it? How do you switch off at the end of the day?
I spend time with I live with my boyfriend and my dog, so my dog is great therapy. We've got some therapy dogs at the hospice.
We have, yeah, wonderful dogs, yeah.
To me, that's my therapy. I love dogs.
Is it? Dogs.
Yeah.
And we were talking during the commercial break about, was it about food?
Yes.
That you're the main cook at the house?
Yes.
Yeah. So what are you cooking tonight?
I don't know.
You don't know?
No. It's coming close to Christmas, so I'm trying to save some money.
Okay.
But I made a chicken pie last week that I might give another go. Didn't make the pastry.
That's okay. I think not
Bought the
many of us-
pastry ready rolled.
No,
but
but you can buy pastry and it's really good, isn't it? Why make pastry if you can buy
exactly.
it?
It's only £1 from
Yeah, it is, yeah.
Only a
Wonderful. Okay. Now, what would you say to someone who's thinking about working in hospice care?
It's a wonderful place to work, to be honest. Yeah, everyone. When I tell people I work at hospice, I was like, oh,
Yeah.
it's like, but it's sad, obviously. But it's such a privilege to be able to work with the patients and their families. And for me, you only die once. Like, you only are born once, and
Yes.
it's such an important time of your life. And to be brought into that for somebody and to make that easier for somebody, like, it's just such a privilege. And the whole team are just wonderful. It's bright and airy, and it's got absolutely gorgeous gardens, and the sun rises up over the gardens. So especially this time of year when it's
Yes.
dark in the morning, you get to see a beautiful sunrise.
Yeah.
So
I could not have put that better myself. Hospices are amazing places. They are not the things that most people think. They're very homely, and I always say this when I walk into a hospice, especially Rotherham Hospice, every day in the morning, I just get this massive big hug. And I'm not the only one. Our patients say that, our visitors say that. Other professionals from other organisations who come, they say exactly the same thing. And I think that it's so appropriate when you can do that. So I'm just going to close the programme now. I want to thank Rosie for your time and sharing your wonderful journey.
thanks for having me.
And carry on doing what you do, because you're amazing. I'll be back next week for another programme. Until then, Allah Hafiz. Bye bye.